I am not going to tell you in the next 20-25 minutes lots of things that you already know about infection prevention and control. I'm going to talk about a bigger picture, the bigger picture, and actually try and address that title. But in doing so, hopefully you realise it's sort of impossible in 25 minutes to talk in detail about the multitude of different aspects of what infection management, which includes prevention, it includes treatment, it includes diagnosis, it includes surveillance and so on. It's impossible to do that. So I'm going to be selective. I can guarantee you will learn something, and hopefully some of that will be helpful for you going forwards. But I'll also, in doing so, take you out of your comfort zone. All right? So you have been warned. You should know everything on this slide, or thereabouts. It's just data. The bit you'll absolutely know is the bottom, HCAI prevalence rate. But the sort of the stark facts on a global level are also shown top left and top right. So that's sort of why this talk matters on a macro scale. These are old data from at least 3 different studies. You may or may not be able to see the references at the bottom, possibly cut off by the chairs. But the message here is if you choose an incorrect antibiotic or combination of antibiotics, and the definition of incorrect is that ultimately the bug or bugs are shown to be resistant to those antibiotics. If you make a bad guess, then the chance of dying, whether you've got ventilator-associated pneumonia on the left, whether you're critically ill, that's lots of different things obviously in the middle, or whether you've got a bloodstream infection on the right, your chance of dying doubles compared with if your initial antibiotic choice is good. It's a good guess. And those data, I say, are old, but they're true to this day. But of course, one view of life, knowing those data, is that you throw the kitchen sink at each and every patient to avoid that risk of doubling their mortality. But on the other hand, we've got all these needs to control resistance and not only think about this patient, but think about the next patient. Our duty, of course, our main duty is to this patient, but we can't treat this patient without any regard whatsoever to the next patients we treat. So we have this tug of war between not wanting to do harm by guessing incorrectly, and then this other need to control resistance. So I'm going to run through, and I've just chosen these at random, 4 different approaches to how we can get better at infection management. Again, management is incorporating all those different aspects, but I'm going to concentrate on specific ones. And to start off, I'm going to remind you of a report that was published over 10 years ago now, and this was a report by Jim O'Neill, and it was commissioned by the government at the time, and it was a hard-hitting report that covered lots of things, lots of aspects of how to address resistance, antimicrobial resistance, and one part of it, just one part, focused on diagnostics. How good or bad are we at diagnosing infection accurately? Remembering, and I'll give you this fact later on again, that 80%, 4 out of 5 of every antibiotic prescriptions are guesswork. Posh term for that is empirical therapy, but it's guesswork. So one of the recommendations was that, and you can see, I'm not going to read out what's in that box, But I just ask you the simple question, have we moved much closer to a mandatory use of a diagnostic for each and every infection? And the answer is we've moved barely at all. And indeed, the government's response to that report did actually say, quote, no antibiotic without a diagnostic test or some sort of clinical score by 2020. So we're only 6 years and counting late. The response also talked about the Longitude Prize, and it talked about some other issues as well. I'll mention some of those in a minute. So one of the responses has been we've had a series of National Action Plans, NAPs for short. And indeed, this is the third National Action Plan. It was published in 2024. And you can see, I'm going to read everything on here, but importantly, this is a massive plan. It's got 9 strategic outcomes across 4 different sectors, and the sectors are listed there. And there are potentially over 500 deliverables across various parts of government, and not just Departments of Health and Social Care, Agriculture, and lots of others as well. I have just had to, was it last week or the week before, go through, we're trying to do a reset of this National Action Plan, and we've identified 153 potential interventions that, from an infection perspective, that I had to rank. I had 20 points to spend, could give a maximum of 5 points to any one of those 153 interventions in a process to try and focus what we're doing, because there's too much in this plan, particularly given the massive reorganisation of healthcare, the disappearance of NHS England, the 10-year plan, which has been published since this was published, and so on. So there's a series of targets within this NAP, and you can see some of them there. And so, some of them will resonate with you because you know about gram-negative bloodstream infection targets and the need to control antibiotic use and so on. The detail doesn't matter. This is just telling you about national policy. But national policy is in a state of transition. I'm going to come back to, right at the end, towards where it is transitioning to, which will be, I think, of some interest to you. So approach 2, what about international policy and international targets to make a difference? So I went to this meeting in France last autumn. It had 39 organisations represented. This was an invitation only. Dame Sally Davis should have been at this meeting. Unfortunately, she couldn't attend at the last minute. But it was specifically addressing the issue of diagnostics. How good are we at developing diagnostics, using them, and so on. And lots of words on this slide, but the key issue that was identified is that from all this effort to produce all these diagnostics, some of them very expensive and large, some of them very small and cheap, is that we have very poor data to understand the value of diagnostics. And that, it might seem a bit odd that I'm saying that to you, but actually we only started the process of trying to value, put a price on what they're worth, antibiotics, about 5 to 10 years ago, and we've barely even started with diagnostics. And unless you understand the value of a diagnostic, how do you know whether it's worth paying whatever they're asking for, whether it's £2 for a lateral flow device or £350 for some of the diagnostic tests that are on the market? That's one use, £350. So this was the UK is a world leader at valuing antibiotics. Out of this work that was done, started pre-pandemic, concluded in the early part of the pandemic, came the NICE subscription model, where contracts are awarded to companies based on the value of their antibiotics. And it's a pull incentive to incentivize pharmaceutical companies to stay in the antibiotic space. Should we have something similar for diagnostic companies? Well, the way you value an antibiotic is simply, I wish it was simple, but it's according to these steady, STEDI principles. And I was involved in trying to value the 2 antibiotics that eventually had contracts awarded by the UK government. And other governments around the world are now copying this process because it's seen as the way forwards, but it's just for antibiotics at the moment. So if you were going to move forwards and try and do something similar for diagnostics to incentivize the market, but only to incentivize it in a way that gave us diagnostics that were worth paying for, you need a slightly different framework, and this concept of strides, and that's what the STRIDES stand for. So they've added in an extra S and an I. And you might think, well, why is he telling you all this? Because it's not really relevant to me on my everyday practice. Well, but it is. And the thing I would say is, on a smaller scale, ask yourself, what is the value? Why am I doing this test? If I'm not going to take any notice and change management of this patient based on the results of this test, then you probably shouldn't be performing it in the first place. So there's a lot of detail on here, but I just want to run through it because this is my Bible, or Quran, whatever you want, of why the correct approach to diagnostics matters. I told you that 80% of the use of antibiotics is guesswork. I've told you that already. But when we start an antibiotic, you know how difficult it is to get a prescriber to stop that antibiotic. So the key thing about a diagnostic, a very key thing before you know anything else is that diagnostic trying to rule in or rule out infection? And diagnostics are developed to be good at one or the other usually, or at least they should be. If they're not good at ruling in and they're not good at ruling out, then they're largely useless. The posh term for ruling in and ruling out is the predictive value. It's in bold later on, the positive predictive value and the negative predictive value. Lots of times you'll hear people talk about the sensitivity of a test, the specificity of the test. That's not important. It's how good are they at ruling in or ruling out. What confidence do you have that the test says there's no infection, or the test says there is an infection? And a clever test might say, well, it's caused by this bug, and a really clever test would say, well, it's caused by this bug and it's susceptible to X, Y, Z. So I mentioned earlier on, do you remember from the O'Neill report about one of the commitments of the government was to institute the Longitude Prize. It only took 10 years from inception to awarding that prize, and the winner was a near-patient UTI diagnostic that's about the size of a bread-making machine and is meant to sit in GP clinics and will give you a 30-minute answer as to whether there is a UTI present or not. And a few minutes later, it will give you antibiotic susceptibility test results as well. But that was 10 years of incentivization to come up with one prize winner. This test was developed by one of the biggest diagnostic companies in the world, Abbott. It was released for 2 years, taken off the market because they realised it wasn't fit for release, altered, re-released, taken off the market after about 2 years because no one was buying it. This is the one that cost £350 per test. And it could identify any virus, bacterium, fungus, protozoan, parasite that was allegedly that was in blood, urine, whatever biological fluid you wanted to use. But no one could afford to use it, and so they had to give up on the multi-million-pound process that this involved. So if you contrast that approach, top left, with a lateral flow device that governed our lives for at least a couple of years, didn't they? And you can see the analogy here. And sadly, it was revolutionary what these LFDs did, but I fear we're losing momentum in that when was the last time you carried out a lateral flow device test on yourself or on somebody else? And the answer is probably quite a many months or years. And yet it had the potential to revolutionize things. So we are trying hard now to incentivize companies to produce lateral flow devices that we need today. And if you're going to do a test, this is just a quick one for you. We're used to the concept of doing one test on a patient. But if you're trying to measure a biomarker, this is something that the body produces in response to infection. And there's different biomarkers. You'll know about PCT, you'll know about CRP, and you'll know less about the other three. That doesn't matter. But rather than just thinking about doing one test in a patient, if you did 2 tests separated by a period of time, it might only be half an hour, it might be an hour. You look at how quickly these biomarkers change in any one patient. And by doing more than one test, you might actually be able to get a much more accurate result than just doing a test, one test, and it being negative. But if you do the second test, suddenly the amount of biomarker has increased markedly, you get much better information. So that's likely to be the way that we move to in the future towards these biomarker usage. So I'm going to end with something that is going to be very relevant to you, and you may know something about this already, but more will follow, he said confidently. So confidently that when I originally started off banging this drum in 2018 and it got into the NHS standard contract, unfortunately we were derailed by the pandemic, and so it didn't move forward until now. So you all know that there are targets, they call them initiatives now, I think is the latest term, but they're effectively targets. They may have lost some of their teeth, their financial clout, their whether that's positives or negatives. But those targets, in my opinion, have lost a lot of their value because there isn't a level playing field in terms of how hard trusts, organisations are trying to determine whether infection is present. So we're going to now start adding ascertainment to the targets. And what does ascertainment mean? Well, in the context of C. diff targets, how frequently is your trust collecting stool samples? Or the reverse of that is how frequently are they warning staff not to take a stool sample unless they get permission beforehand, which is ludicrous, but why? Not that uncommon. So we're going to start be able to categorise trusts not just according to their C. diff rate, but how hard have they tried in terms of stool sampling rates, and of those stool samples that have been collected, what's the rate of C. diff testing? In terms of gram-negative bloodstream infections, how can we meaningfully compare trusts or even know how well a trust is performing if we don't know how hard they are trying to carry out blood cultures? So what is their blood culture sampling rate? These data are already collected, but they've never been used in anger. And then in the future, so rather than simply how frequently you're carrying out blood cultures, how well are you doing that? Are you collecting the right volume of blood? And are you getting those blood cultures into an incubator quickly enough? And all those factors affect the chance that the blood cultures will become positive. I spent 6 days for my sins in Munich last week, last but 1 week, straddling into last week, for the ECCMID, the biggest infection conference in the world. And it was really heartwarming to see this presentation from Northumbria, and so I'm giving them due credit, and if there are anyone from Northumbria, please go back and tell them how impressed we are with this work. And this is about how to do the last thing on that list that I had on my slide before, about improving the quality of blood cultures. And there is now a national blood culture pathway, some of you will know about this, to do this sort of work. But just look at the effect that targeting how well blood cultures are taken can have. So there's lots of detail about what they did there. Look at the graph with the red line, improvement in blood volume per bottle. It went up and up and up over the period, the 2-year period of this phased quality improvement plan. The results are summarised in those boxes on the left-hand side, and these are really stark. Because you think, why is he talking about how well a blood culture's performed? Well, if you do it properly, I'd actually put the right amount of blood into the bottles rather than however much is left in the syringe that the phlebotomist or junior doc has got, rather than concentrating on the right amount, the optimal amount. And they increased from 4 mils to 7.2 mils per bottle. Look what happened to the positivity rate of their blood cultures. It went from 9% to 14%, which is a greater than 50% relative increase. How many patients does that represent who had a positive blood culture that would have been missed by not putting the right amount of blood into the blood culture bottles? We have known about the association between the right amount of blood and the wrong amount of blood and blood culture positivity rates for about 40 years. So this is where ascertainment, my drum about ascertainment is important. Their contamination rate didn't change. So it wasn't as though by putting more blood in the bottles, they were just sampling more skin flora by badly taken blood cultures. That increased positivity was almost certainly due to real pathogens that were being missed otherwise. So, hopefully, and I'm sorry if I've taken a view that has surprised you, but I've purposely tried to look at different macro and ending up with micro ways of improving the infection management pathway. Does anybody disagree with any of these statements that we can prevent more infections? And I haven't talked a lot about prevention today, but it's implicit in how we use antibiotics, how well we diagnose infections or not, and so on. We can improve outcomes, and I've given you plenty of clues and showed you some real-world data at the end. We can slow down antibiotic resistance, and the best way, simple way of doing that is use fewer antibiotics when they're inappropriate, but not when they are appropriate. And last but not least, we can get better at diagnosing infection.